Well, good morning to everybody joining us this morning. It looks like we're going to have a big group today on this very important topic today on COVID-19 and the flu. Welcome back for those that have joined us before. We've done a whole series of these if you have not participated, and we started several months ago just on hot topics that we know would be at the forefront of people's questions. So we try to get ahead of that and answer as many things as we can. We've had a great group of experts on these webinars. So we definitely thank all of our subject matter experts that have participated, especially through the University of Texas. We certainly could not have done this without you. A special thanks to Michelle McDaniel with UT and Jordan Huggins with HASC for helping us coordinate all this and wrangling all of these subject matter experts. Sometimes that's not easy to do, but we thank you for being here. We think this is going to be an enlightening topic and one that is important throughout this pandemic and especially this fall season as we're approaching. So again, thanks to everybody for joining us here. I'm going to start clicking through our slides here. If you joined us before, you know the process. There's a question box on your screen. We cannot hear you, so if you're chatting away, we can't hear a word you're saying. If you want to talk to us or ask questions, just type it into that question box there. We can see those in real time, and we're going to answer all of those that we can. And believe me, we don't like just sitting here and talking and showing slides. We feed off your engagement and your questions. So please just feel free to shoot them to us. You can start shooting those questions now, and we're going to go through them as we're going through the session. And then at the very end, that's when we really dive into those questions. So again, thanks for being here. The webinar series have been brought to you by HASC, the Houston Area Safety Council, and the UT School of Public Health. Those two entities are here to provide education, to provide safe workplaces, and to change the culture of health. So these are geared towards you, the employer, to the employee, to the workforce, to make sure that you have all of the latest and greatest education and data and science out there throughout this pandemic to make good choices for your workplace. Thank you to our HASC sponsors. We could not do this without your generous support. Thank you to all of the donors and supporters of the School of Public Health. I know they greatly appreciate it. We greatly appreciate it, and we value those relationships. So just a few graphs. You know, we really tried this time not to put in a whole bunch of scientific graphs and charts. I think everybody's inundated with that stuff and keeps track of those things on the news. But just to give you a snapshot of how the U.S. as a whole is doing with daily cases. Here's the graph of U.S. new daily cases. You can see it's up and down throughout this pandemic. We are on the downturn, hopefully a long-term downturn. You can see at the very end there over the past couple of a week or so, we have seen that little bit of a spike. We're hoping that that's going to level off and go down. We're hoping that that's just maybe from Labor Day, people had a good time and we see that increase. And hopefully it shoots back down. What we don't want to see is, you know, you can see the July 1st trend. We don't want to see that big spike again. And we're hoping that doesn't happen throughout this fall season, which is why we're going to talk about that today. Positivity rate, this is the number of people testing positive that have had a test. And you can see that we're doing a pretty good job with that. It's gone down to around 5%. Up from a high of 20% when this first kicked off way back in April. So that has a lot to do with the social distancing, the facial covering. You know, we're getting it now, I think, and we're doing what we can, and that translates into good numbers there. I'm going to pass it over to George to talk about this. Go ahead.
Can we go back to the previous slide for a second?
Yeah.
So what's important here is the positivity rate for the country as a whole. That's an average value, is getting better and better, but that doesn't mean that there aren't states that are not higher than that. In fact, there are many states now that are still well above the desired 5% or lower positivity rate. So we need to take into account that when we're looking at U.S. numbers, there's a lot of noise around those numbers because of variation from state to state. I don't know what it is for Texas today, but it had been getting closer and closer to the 5% rate as of about a week ago. So that's a good sign, at least for Texas. Okay.
Absolutely.
Slide.
Yeah. When I checked the positivity rate for Texas yesterday, it was around 6.8%. So getting much better.
Okay, so a little bit about flu, and Tommy's going to talk about the characteristics of flu, but one point I want to make with this slide is that, and the reason for this webinar is that every year we have flu season. It is fairly predictable, although there have been some exceptions historically. And what you see here are several years worth of flu seasons, one on top of the other, and it shows that it's a fairly consistent period of time when the flu appears. And this is from the CDC. And what we have down the numbers below from 40 all the way to 38, excuse me, 40 to 52, and then it starts over again. These are weeks of the year. So the first week in January is week 1, the second week is week 2, etc. And you'll see that typically we start seeing flu activity in the US beginning about weeks 40 to 44. So that puts us in October, early November. And then it starts peaking around the beginning of the year in January, and then it lasts for about 2 to 3 months after that before it starts going down. It's important to remember that this pattern, because it does have implications when we later talk about the flu vaccination and the possible collision of flu and COVID this year. So right now, you probably heard that we are encouraging flu shots already, even though there are no cases really in the community just yet. We want to vaccinate ahead of time before we start seeing the numbers appear in the community. So that's all I wanted to say about this slide, and then we'll talk a little bit more about it later.
Well, let's jump into a little bit to talk about, well, what are the similarities of these two viruses? Because they're, as you're going to see, they're extremely similar. The similarities greatly outweigh the differences when it comes to these two viruses, which is a problem. So how contagious are these two viruses? When we look at them, at any contagious disease, we look at how many people is an infected person going to spread it to on average. So we have that number. It's called an R0, a reproductive number. So for the flu, for any one person that has the flu, the chances that they're going to spread it to about 1.3 people, more people on average. When you compare that to COVID-19, it has a reproductive rate of around 2. Okay, so from 1.3 to 2. So some people, glass half full or glass half empty. You could say, well, that's not too much more contagious than the flu is. Some people may say, that's almost double what the flu is. So it depends on how you want to look at it. It is greater than the flu, but as you can see, when you compare it to other contagious diseases like measles, if somebody gets the measles, they're likely to pass it to 18 people. So greatly less contagiousness than the measles, but still higher than the flu when we're talking about COVID. When you look at something historical like the H1N1 2009 spread, that had about a 1.5 reproduction rate. So when it's good to know these rates to see, well, how contagious is this virus? When COVID-19 was first spreading, February, March, we had no clue what that R number was. We thought it could be up to 4. We thought it was a lot more deadly than it was. We just didn't know, and we're still learning. But I think we have a better understanding now, and you can see that reproduction rate of COVID is around 2. For the flu, it's around 1.3. George, did you want to add anything to that?
Yeah. So these reproduction numbers reflect the likelihood of passing it on to more than to other people when you take no protective measures, because these numbers can be affected. We can make them lower than they are, and in fact, we are starting to do that with COVID. The current reproduction number for COVID in Texas, in Texas, is below 1, so which is great. That means that there are fewer infections being transmitted in the community. We're still not where we want to be, but by reducing it to below 1, then it makes it less likely that even one person with COVID will spread it to another. But that's done through adherence to the safety practices that you've all been hearing about every single day: universal masking, social distancing, avoiding large gatherings, good hand washing. That's how you can affect this baseline reproduction number of 2 and lower it. And that's true for any disease.
Excellent. So, I did this one slide on just a snapshot, an introductory snapshot of how these things are similar. So they're both contagious respiratory viruses. Yes, can you touch something that's contaminated? Can you touch a doorknob and get the flu? Can you touch a doorknob and get COVID? Yeah, we think so, but definitely not the primary source of contagiousness, right? It's a respiratory virus. You breathe in droplets to get the virus more often than not. Both the flu and COVID-19 share many of the same symptoms. We're gonna look at that, and you're gonna be shocked to see the similarities versus the differences. Both can be contagious before you even know you got it. And that's what the scary part has been about COVID, is that you can be contagious and pass it and you don't even know you're sick. And that's why people go and they feel great. They go to Aunt Sally's house to go visit her and the grandma and the family reunion and the birthday party. Nobody is aware that they're sick. There's no signs or symptoms. Nobody's coughing. Nobody's got a fever. Nobody's got body aches, and they spread it to everybody at the party, because you can spread this thing before you even know you got it. Both can cause severe illnesses, especially to those at higher risk, the elderly, those with comorbidities. It can cause severe disease. It can cause death in both of those. So when we look at the actual symptoms of COVID-19 and the flu, you're going to see how great those similarities are. Both can cause a fever. If you've ever had the flu, you know you get a fever, right? COVID-19, one of the top signs and symptoms of COVID-19 is a fever. Cough, they're both respiratory viruses. Most likely you're going to get a cough, or shortness of breath, or feeling like you can't breathe, you're having difficulty breathing. Both make you tired. It just knocks you out. You feel fatigued, you feel tired, you don't want to get out of bed. Both can cause a sore throat. Both can cause runny or stuffy nose, muscle pain, body aches. I saw 2 patients, both tested positive for COVID, and they both thought they had a back strain. Their back muscles hurt. Sometimes that's all it is. Headache is another one, and some people have those GI symptoms. So this is your list of comparison between COVID-19 and the flu. Both can cause these. Well, what else can cause these? The common cold, any other virus you can think of. What about strep throat, sore throat, headache, body aches, fatigue? There's a lot of these viruses and bacterial infections can cause a whole host of different things. So what we're seeing with the flu and COVID-19 is a lot of these symptoms are the same, and they're indistinguishable. If somebody walked in and had all of these to see Dr. Delclose or myself, I can't look at you and tell what you got. I'd probably say, well, you either got COVID or you got the flu or you got the cold or some other virus. That's when we have to go to our testing and try to figure out what's going on. All right, so this is us, right? I don't know, it could be a whole host of things because everything is so similar. So let's look at the list of features and signs and symptoms that can separate these. There's really only one, folks. That weird symptom of a loss or a change in taste and smell, for whatever reason, is a unique symptom to COVID-19. Who knows why? I'm sure there's some studies going on, or maybe there's some studies that have shown why we think that's possible. But this seems to be a unique symptom to COVID-19. So something to kind of be on the lookout for if you do have the whole laundry list of other symptoms, but you lost your taste or you lost your smell, may be an indicator that it's COVID-19. So let's look at some of the differences and similarities to these two viruses. So in the flu, a person can develop symptoms from 1 to 4 days after they've been infected. Okay, they went to see Aunt Sally, and Sally didn't know she had the flu. 1 to 4 days later, you may start to experience signs or symptoms of the flu. It's pretty quick. It's got a short little incubation period, and before you're going to show those signs and symptoms, 1 to 4 days. Let's compare that to COVID-19. We know that you typically will start to show signs and symptoms on the 5th day, 5 days later, but that can vary between 2 and 14 days. So a much wider time frame from when you become infected to when you start to show those signs and symptoms. This is why the guidance is out there. Well, if you think you've been exposed, you better hunker down for 14 days, because it could be on the 14th day before you start to have a fever and cough and sore throat and those signs and symptoms. A much greater span of showing those signs and symptoms from when you became exposed. Now, the problem with the flu or COVID-19 is a lot of the times you don't know when you were exposed. You don't know how you got that virus. So you don't know if you were exposed yesterday or 14 days ago. So that's why we still say when you start showing those signs and symptoms, at least 10 days you need to hunker down, because you could be contagious during that time frame. Let's look at the spread. You know, in flu and COVID-19, a person can be contagious even before they have signs or symptoms. That's been the big issue, right? It's a big issue for the flu, but it's been a pressing issue for COVID-19, because you're going to be walking around spreading that virus and not know that you have any virus at all floating in your body. This is why the facial coverings, the social distancing has been so important to try to squash the spreading of that virus, because again, you're walking around spreading the virus without a cough, without a fever, without even knowing you have it. And the same holds true for the flu. You can be contagious during that time frame and not have any signs or symptoms, and going out to that family reunion or that birthday party spreading the flu to everybody. So they're very similar in that regard. Both flu and COVID, a person can be contagious if they don't have any symptoms or very mild symptoms, just like we said. Again, facial covering, social distancing is important to keep those numbers down. In the flu, a person is most contagious during that first 3 to 4 days of having the illness, in up to 7 days, right? So in general, the flu comes on quick after you've been exposed, and it goes away quick. You know, if you talk to anybody that has ever had the flu, they say it was the worst week of my life. But it's just a week. Typically, you're going to get the virus, you're going to get sick, it's going to go away within a week. You contrast that to COVID-19, and you can be contagious up to 10 days after those symptoms first start. So, and again, Dr. Emery, who is usually on these webinars with us, always likes to point out this is a novel virus, meaning it's new. We still don't know a lot about this virus, right? We think, and we know more now, right? We've been through this now for almost 6-9 months. A person can be contagious at least 10 days after those symptoms start. That's why we say, you got symptoms, go home, stay by yourself, hunker down, because it's a wider time frame of being contagious than we know the flu is. George, did you want to add anything?
No. In some people that have had COVID, some people who have a pre-existing disease that makes their defenses be worse, that lowers their immune response, that contagiousness can last longer than 10 days. It may, typically about 95% of them are stop being contagious after day 15. But this is only in people that, for what we know now, that have an underlying immunosuppressive disease. So for those folks, we tend to return them to work. We wait a little bit longer than we wait for example, employees who have had COVID. And typically we'll start talking about getting them back to work as long as they're without a fever and they feel better after about day 10. But these other folks with pre-existing immune conditions, we may wait a little bit longer on them.
You know, and just to point out, and I know George is going to talk about this a little later, but don't get the impression that these things are mutually exclusive, right? If you got the flu and COVID, then all bets are off for this timeline, right? It could start early because you've got the flu. If you've also got COVID, it could last 14 days. So these things certainly can be caught together and give you an even wider variety of signs and symptoms, being contagious. So just keep that in mind as we're talking about this. We try to separate them to show you the differences and the similarities, but if they're combined and they're together and you caught both, you have to keep that in mind. So treatments, I think we all are aware that Tamiflu is out there. There's other newer antiviral treatment for the flu, but Tamiflu is the tried and true. It's I believe it's generic now. I believe you can get it a little bit cheaper, but you know, that helps to reduce the duration of the flu. It helps to reduce some of your symptoms. It doesn't make the flu go completely away. It helps suppress the virus, which makes your symptoms get better faster, and that week of feeling miserable lessened by a couple of days.
Tommy, can I add for Tamiflu? Yeah, Tamiflu is also useful for preventing the flu. If somebody in your family has the flu and it's clear-cut flu, there may be some value in you taking Tamiflu before you get the flu, because it reduces your chances of getting it, even if you've been vaccinated.
In COVID-19, you know, there's some emerging treatment options out there. You know, most of these, if not all, are still being studied. We still don't know everything there is to know about these things. The convalescent plasma therapy that we all hear about, that you know, Tom Hanks has been a spokesman for, because he's in one of those trials donating his plasma. Still being investigated. I would, and George, please jump on board with this discussion, but I think the jury's still out if this is a really good treatment or not with the plasma therapy. Remdesivir is one that we've all heard about on the news. It certainly is being studied. Certainly trials going on. I know if you go to a hospital here in Houston and you're in bad shape with COVID-19, there's a chance you may be given remdesivir in one of those trials to see if it helps you out. We think it may reduce severity, may reduce the duration of that disease, but right now it's limited to those that are in critical condition in the hospital setting. Steroids are something that are being recommended for right now for severe disease. Again, there's several steroids that you can give. Right now, the guidance is the steroids for severe cases in more of a hospital setting, but there's a lot of times no harm in giving a simple steroid pack to somebody who's got a cough or shortness of breath. The steroids are still a good option for those cases as well. So vaccination, get a flu shot. The flu shot has been a tried and true prevention for the influenza every year. Some years it's better than others. Some years it's more effective than others. Get a flu shot. There's no reason not to get a flu shot. Offer flu shots to your employees. Make it easy for them to get a flu shot. You saw the list of similarities between the flu and COVID. If you can prevent one of those completely, or at least 50% of the time, why wouldn't you do that? Why wouldn't you want to just get flu out of your mind? Okay, all my employees have been vaccinated. If somebody comes to me with fever and cough and shortness of breath, the chances that it's the flu are diminished. Now we can try to focus in on COVID-19. So offer that to your employees. Make sure that it's available. The flu shot is still cheap. It's going to run you $30, $35, $40 most likely. There's no reason why you shouldn't get the flu. I realize that some people say, well, I got the flu 3 years ago, and I got the flu shot and I think it made me get the flu, which we know is not the case. So try to encourage your workers to get their flu shot. Dr. Delclose and I were chatting that the hospital that he works for in the medical center does a flu shot campaign. You know, make posters, send out emails, encourage those workers to get the flu shot this year, especially this year, right? When we've got two major viruses potentially on a collision course, get the flu shot. I know there's some questions coming in about the different varieties of flu shots this year, the dosing. So we'll definitely chat about that a little bit later. So when we look at the COVID-19 vaccines, we're almost there. It looks like we're almost there. Several vaccination and pharmaceutical companies are in their final stages of testing. Appears that a vaccine will be released by the end of the year, or approved by the end of the year, and then start going into its mass production to put out tens of millions of doses for everybody in the United States. Here's our current COVID vaccine tracker that I copied today from the New York Times. So you can see 26 pharmaceutical companies or vaccines in phase 1, 14 in phase 2, and 10 in phase 3. The limited ones you see that are 5 are probably not ones that we're dealing with in this country. Russia came out with one. I think China has come out with one. Those are not us, right? We're in the phase 3 at the best. So I saw Johnson & Johnson is going full steam ahead in phase 3, which looks promising, which is I think they're looking at a 1-dose vaccine, which is good. Some of the other ones are at least 2 doses. So promising vaccines. It looks like it, from everything that we know right now, looks like it's good efficacy. It looks like some of these are gonna build strong immune responses with few side effects, but they're, again, still have to finish out phase 3 to make sure that's all under control. So I'm going to pass this over now to George to talk a little bit about, well, what does this look like if these two viruses combine this year? What are we looking at?
Sure. So with respect to COVID and the flu coming together, there's good news and bad news. I'll start with the bad news. One is a dreaded scenario. If we don't do things correctly, there is a possibility of a combined wave of both viruses hitting the U.S. at a time that I think it's fair to characterize it as the worst public health crisis of our time. When we listen on TV and for comparisons, everybody goes back to the Spanish flu, the swine flu, at the turn of the 20th century, at the beginning, it was 1916 or 1917. But since then, I think it's fair to characterize what we are going through right now as the worst public health crisis of our time, and it can be made worse if we don't do a good job of anticipating what the combined effects of having to deal with both of these viral infections will be, and especially if we are lax with taking safety measures. Both viruses, so Tommy talked about the presenting symptoms, but it's also important to talk about the fact that both viruses, in some cases, can cause very severe disease and even death. It's not just COVID-19 that can cause death. Flu can cause death and lots of hospitalizations, particularly at risk of severe complications from the flu. The groups are very similar to the high-risk groups from COVID. So we're talking about the elderly. We're talking about people with asthma or with heart disease or prior history of stroke, diabetes, maybe people with some immune suppressive conditions like HIV/AIDS, or even cancer that also can be associated with immune suppression. And then with the flu, there are some additional differences. So for example, children, very young children who get the flu are also at risk of getting severe disease and dying, especially children under the age of 2. That's why we encourage all pregnant women to get flu shots. No questions, no need to get a doctor's release to get a flu shot. If you're pregnant, get a flu shot. Next. So people ask, is it possible to have both infections at the same time? The answer is yes. We don't know how common it is, but we do know that it has been reported in very good, what we call case studies, descriptions of specific patients who were tested for both. A lot of these cases were described very early on, actually in March, April, coming out of China, which is what you'd expect since that was the first country to have the infection. So they can occur. And why is this important? Co-infection, if it does occur, is important because it may especially affect these most vulnerable folks and probably increase the chances of death greater than either of the two infections by themselves. I'm saying probably because we don't know that for sure, but it is a reasonable assumption. And so those vulnerable to either of the two infections tend to be affected most severely. But there's also some good news, which is going to be on the next slide because I forgot this last point. The other, let's go back. Can we go back to the previous one? Yeah. So the other thing, and the other reason to get ahead of this double pandemic or double epidemic is because we've already seen what happens when our hospitals are overwhelmed by COVID. We saw it in New York, we saw it in several other states, we saw it around the world. If you add flu to the mix, you know, flu results in a lot of hospitalizations every year. And so if you've got two epidemics going on at the same time, that may stretch our hospital capacity again. And when hospital capacity is stretched, then that increases the likelihood of a bad outcome, not only for the patients, but also for the people taking care of those patients, because PPE, for example, will be in short supply again. And so we need to anticipate this so that our health system, our hospital system is able to meet the challenge, you know, to have enough surge capacity to deal with it. Now we'll go to the good news. So in the good news, we do know that the same protective measures for COVID, universal masking, safe distancing, safe social distancing, avoiding crowds, good hand washing, are also good practices for preventing the flu. In fact, and I'm not saying this is going to happen in the US, I hope it does, but we've already seen that in countries whose flu season has already come and gone, like Australia, typically countries in the southern hemisphere of the world will get the flu, well, their flu season comes before ours. In Australia, they have noticed a drastic reduction in flu cases this year. And when I talk about drastic, I'm talking about 60, 70 or more % reduction as compared to previous years, which is phenomenal. Now, it's also true that Australia is much stricter than we are on things like lockdowns, penalties for not complying with masking or social distancing, etc. So it's a good example, but we would have to, it would be ideal if we could reach that level of protection. But that's good news. So we may in fact see a lower flu season. However, I don't want this to be misinterpreted, because just because there's a chance that everything we're doing now to protect ourselves against COVID might have the benefit of reducing flu, that's not an excuse for not getting the flu shot. Okay? Other good news is there is treatment for both infections. Tommy covered that very well. So for the flu, we have we have preventive treatment, but then the specific treatment when you have the disease, we have that for the flu, Tamiflu, either when you have it or when you've been exposed to somebody who has it to prevent it. For COVID, even though a lot of the results are still pending, we do know some things, such as the role of steroids in advanced disease, maybe even remdesivir in severe, but it's different for each. And in fact, I would say that one of the reasons to try and make sure that we as clinicians can separate between the flu and COVID is that sometimes the treatment that is good for one may not be good for the other. So for example, typically in the flu, we don't give steroids. There are exceptions to that. If you have asthma and the flu causes a bad asthma attack, we will give you steroids in those cases. But typically, it's not part of the treatment for flu. It is part of the treatment for COVID-19, at least in moderate to severe cases with respiratory diseases. We do know that the flu vaccination is effective. It's given every year. It changes every year. This year's vaccination is targeting 4 different strains of the flu virus. And so the type of vaccine that is being recommended by CDC is what's called a quadrivalent vaccine. That means it's got protection against all 4. And as Dr. Heisler said, there are promising vaccines for the other for COVID as well. However, I think it's probably safe to assume that neither vaccine is going to be 100% effective. There are very, very few vaccines for any disease in the world that are close, that are 100% effective. Some are very close, like measles, like polio, but the majority are not at 100%. So for example, your typical flu vaccine may be effective in up to about 70% of cases. Last year's flu vaccine was not very good. It was as low as around 40, 45%. Still, it's better than zero, but it was not as effective as in other years. We think this year's flu vaccine, the quadrivalent, is going to be more effective, but we won't know until obviously flu season is here. That's still not a reason not to get it, because if you have a vaccine that's 70% effective, that's a lot of protection. And the same thing with COVID. You know, we don't know if it'll be 50% effective, 70% effective, 80% effective, which also brings up another point that because neither of these vaccines is 100% effective, I don't see that we're going to be relaxing masking and social distancing and the other safe practices anytime soon, even if we have the vaccines available. And when we do have those vaccines for COVID, and now that we have the flu shot, I'm a big advocate of mass population vaccination. We can't require it in the US, but when this becomes available, just in the same way that we encourage flu vaccination in the entire population greater than 6 months of age, we're going to be doing the same thing, I hope, for COVID, because the greater the percentage of the population that is vaccinated, the more likely we are to get close to that desired herd immunity that we've talked about in other webinars.
All right, so that looks like the end of our formal discussion on the flu and COVID-19. George, I know there was a question written in by one of our colleagues from UT Tyler asking about the different doses of the flu vaccine. You want to talk about that,
right?
The super dose or the senior dose, or the more powerful ones?
I think I saw the name Jeff roll by.
Yeah.
Hi, Jeff. Hi, Dr. Levine. Good to hear from you. Yeah, so there are the vaccines that we have for flu this year fall into different categories. There are still some that only protect against 3 of the 4 viruses. CDC is strongly recommending that that we protect against all 4 strains of the flu virus. There is also one that is more potent. It's called a high-dose flu vaccination. And typically the use of that is limited to people 65 years of age or older. And then we have a nasal vaccine that is also on the list of acceptable vaccinations listed by CDC, although it tends to be given less. So let me address the high dose vaccine for people 65 and older versus the standard quadrivalent flu shot that is being recommended this year. CDC does not express a preference for either the high dose or the standard dose. They say both are acceptable. If you go to their website, they do present some data on a few studies that have looked at the effectiveness of high dose flu shots in people 65 and older, and there does seem to be some benefit. Apparently, it's not enough benefit for CDC to recommend it over the standard dose vaccine. So it puts it in the, and they're very clear that they don't recommend one over the other, but they present the data to you. So, it's certainly understandable that people over 65 would prefer to have the high dose vaccine. I can tell you, because we're also in the midst of our flu vaccinations here in the Texas, or flu campaign in the Texas Medical Center, that it is increasingly difficult to get. In fact, we have not been able to get it this year. I think some of the pharmacy chains like CVS or Walgreens may be offering it, and if you do that, that's your choice, and it's okay, it's fine. It's a perfectly fine choice if you're 65 or older, but don't be surprised if they don't have it. And it should not be a reason that the absence or the lack of availability of a high dose flu shot, if you're 65 or older, should not be a reason to not get the standard dose. Get whatever you can get your hands on that is recommended.
Along the same lines of vaccinations, there was a good question about the pneumonia vaccine. You want to chat briefly about who is recommended to get the pneumonia vaccine, and what specific disease, agent the pneumonia vaccine prevents?
Right. So that's a good question as well. So, well, first of all, pneumonia just means an infection of the lung. There are viral pneumonias, pneumonias caused by viruses. COVID and flu both are good examples of viruses that are capable of producing pneumonia. And then there are pneumonias that are caused by bacteria. Bacteria are things that you give antibiotics for. You don't give antibiotics for viruses, but you do give them for bacteria. The pneumonia vaccine targets one of the most common types of bacterial pneumonia, specifically streptococcal, which is a bacterium pneumonia. And there are two types of pneumonia vaccine. One has been around for, gosh, now it's probably closer to 30 years, I'd say. It's called Pneumovax, and it protects against 23 different serotypes. If you want to call them strains, you can call them strains of the pneumococcus. And I think I said streptococcus before, but it's actually, it is a streptococcus, but it's really the pneumococcal vaccination. And then more recently, a separate vaccine called Prevnar 13 protects against an additional 13 serotypes. So who is it recommended to get the pneumonia vaccine? Unlike the flu shot, unlike COVID vaccination when it comes around, it's not recommended for the entire population until they hit a certain age, which is 65. Or if you're younger than 65, but you have pre-existing heart or lung conditions, then diseases, then it's a good idea to get these vaccinations. The full series involves getting both vaccinations, both shots, the Pneumovax and the Prevnar, separated by 1 year. Typically, if you've never had the pneumococcal vaccination and you are a candidate for it, they will probably give you the Prevnar 13, the newer one first, and then 12 months later, they'll give you the Pneumovax. And after age 65, you only need to get one of each. It doesn't need to be repeated, unlike the flu shot, which needs to be repeated every year. It's good added protection. It does not protect against all types of pneumonia, just like the flu shot does not protect against all types of respiratory infections. It just protects against the flu. And the pneumococcal vaccine just protects against the pneumococcal pneumonia. But it's a good thing to have. It is covered by insurance. A lot of these insurance plans, because it's prevention, there's probably no copay, certainly under Medicare. That's likely to be the case. And I would encourage it if you meet the criteria.
So no updated recommendations if you've had COVID pneumonia that you need a pneumonia vaccine. No relation to those.
No, I mean, it is still recommended. In many hospitals, if you're sick enough to be admitted to the hospital, or if you're admitted electively to hospitals, a lot of hospitals will give it to you as you walk through the door if you haven't had it.
A question was directed to me. Are there confirmed COVID-19 cases where individuals did not have that loss of taste and smell? Absolutely. You certainly don't have to have everything on that list. I would say that loss of taste and smell is not one of the higher up symptoms on the list. The higher up symptoms are going to be your fever and cough, and loss of taste and smell is down the list, but it just happens to be a weird one.
30-35%.
Yeah. So to answer the question, absolutely, you can have COVID-19 and never have loss of taste and smell. And remember, you can have COVID-19 and have none of those symptoms on that list. You can be completely asymptomatic. So it's a good question. A good question, and one of emerging importance and kind of changes daily. George, you want to talk a little bit about droplets versus aerosols and what we think is spreading this virus?
Sure. So yeah, it's understandable that there's a lot of confusion about this, and it certainly didn't help when last week CDC came out and said that airborne instead of droplet transmission is the most common form of spread. And then a few days later they retracted it and they said it's not the most common, but it is possible to get it via the airborne route. So let's review droplet versus airborne. So droplet, we're talking about particles that are, when you cough or you even if you breathe or you sneeze, these large particles of secretions that are too large to stay suspended in air for a long time. They tend to fall to the ground, and they fall within a distance of about 6 feet or less. That's the whole rationale for social distancing being based on 6 feet or less. I think most people will agree that for COVID, this is still the main form of transmission, droplet transmission. That doesn't mean that there aren't other forms of transmission. So for example, we know that some surfaces can be contaminated with the virus. And if you touch a contaminated surface and then touch your nose or your mouth, or even your eyes probably, that you might acquire COVID. It is probably not anywhere near as common as droplet transmission. Airborne transmission is when the particles that are released are very, very tiny. And because they're tiny, they tend to stay in air for a longer period of time, and they may in fact travel a longer distance, depending on a bunch of things. For example, if you sneeze or you're coughing or you are singing loudly in a choir or you're yelling, all of those things can increase the distance of travel of these airborne particulates. Other things that can affect it is the ventilation of the system that you are in. So for example, if I am coughing and I've got a fan behind me and you're in front of me, it'll probably take whatever comes out of my mouth and send it farther, and you're at a greater risk. Or if you're in a room that does not exchange air replace the existing air with fresh air at a high enough frequency, that may prolong the persistence of these particles in the air. So airborne transmission, we do know it occurs. It is especially likely to occur in people who have unprotected sneezing, who are singing loudly, who maybe shouting. All of those things increase the likelihood. Why am I saying that still droplet is probably the main mode of transmission? Because of what we're seeing with masks. Masks, I'm not talking about respirator, I'm talking about masks, are not very good at preventing airborne transmission, at cutting it off. It'll cut it off to a certain degree, but not very well. But it is very good at preventing droplet transmission. So what we do know is that masking, when it's practiced correctly, results in a dramatic decrease in the likelihood of contagiousness. And because of that, we think still that the main mode of transmission is droplet, but we don't rule out the other forms, airborne and surface.
Yeah, I know there's been a lot of up and down about that. And, if you've ever watched the movie The Hot Zone, right? I mean, when do they freak out of the movie? When it's airborne, right? So I know that, that kind of, scares people when they think, well, I can just be walking in the grocery store and these little particles are floating around and I'm going to breathe them in. But it, like George said, it doesn't look like that's the main route of transmission, which is.
Well, it scares some people, but it also, what I worry about even more, I'm less worried about people that are scared about that because they're going to take more precautions. I'm more worried about people who use that as a reason to not wear a mask. Oh, masks don't protect against airborne transmission, hence I won't wear a mask. No, that's not true. That's not true. Masks do protect against the main mode of transmission, which is droplet, and we should all be using them.
A question about the slides. Are the slides going to be available? Absolutely. We record this session and we send it out to all of the attendees so you can watch it as many times if you want to. Let's see here. Just like flu viruses differ from year to year, is there any difference? I assume related to COVID. Or do we think it's going to be a new strain every year that we're going to have a new vaccine? What do you think? Yeah, we don't know.
that cartoon you showed.
Yeah,
we don't know. I mean, some of the proteins appear to be pretty stable on the proteins are what on the outer layer of this virus. Everybody's seen the little spikes. So there's something called the spike protein, but there's also the capsid and other types of proteins. Remember that if there's a lot of mutations, the vaccines that we are developing now might not be useful, and yet from what I've been reading, the ones that are being developed that are in phase 3 are targeting proteins that have been pretty consistent in this very short period of time that we have come to meet COVID-19. As Dr. Heisler was saying, let's not forget it's a novel virus. We're still learning, and we can't talk about what it's going to be like the next, next year or 2 years down the line, because we're nowhere near there. We have a lot of good, data on what happens with the flu from decades of studying it. But we're still 9 months into this, only to this new disease.
A good question, and one that I had actually thought about earlier was, if you get a COVID vaccine comes out, you get it. Can you get it with a flu shot as well? And I would imagine that they're doing some of those tests as well. With some of the different vaccines that we routinely get, the manufacturer will say, do not give this other vaccine if you're getting this vaccine. So I don't know the answer to that, but I would assume there's going to be some testing done to make sure that there's no cross-contamination with other vaccines.
They'll certainly be studied, the safety of giving them both. I can tell you, though, as a general rule with vaccinations, vaccines are divided into two big groups. They're called inactivated vaccines. This is where you don't have a live virus. You're just targeting, the vaccine is really targeting a specific protein or something like that. And then you have live virus vaccines. The general rule of thumb is you should never give two live virus vaccines together. But inactivated vaccines, you can generally combine them. Flu shot, except for the nasal one, which is a live virus vaccine, but the regular flu shot that you get in your arm, that is an inactivated one. So it presumably can be given with another inactivator, and frankly, could even be given with another live one. There's no incompatibility if you give one live and one inactive. What you can't do is give two live virus vaccines together, typically.
And I think that's a good segue to another question that always gets asked, and it's been asked here too. Let's talk a little bit about the myth of I got a flu shot and then I got the flu because of it, or I got the flu shot and then I felt miserable the next day and had a fever. What do we know about that relationship?
Okay. So the most important thing for folks to remember is the flu shot does not give you the flu. You cannot catch the flu from the flu shot. Period. End of story. That doesn't mean that the flu shot will prevent other viral respiratory illnesses. So flu shots are not going to prevent the common cold. They're not going to prevent COVID. They're not going to prevent other viral infections like respiratory syncytial virus and some of the other ones. They just protect against the flu. However, you can have a local reaction after getting the flu shot. It doesn't occur very often, but it can occur. So the day after, generally it appears within hours to the day after you receive the flu shot. Some people may have a local reaction. Their arm will swell up a little bit. They may even have a little bit of low-grade fever and possibly even some symptoms, but it is not the flu, okay? This is also going to be important for the COVID vaccine, because even though we are not 100% sure of the safety of the vaccines that are being studied right now, although it's promising, as Dr. Heisler was saying. In the earlier trials, the few adverse reactions to the flu to the COVID vaccine that were being experienced by volunteers, and these were healthy volunteers, some of them did get a couple of days of mild symptoms. That does not mean they got COVID. It means they had a reaction to the vaccine that lasted a day or two, and then they were fine after that. And in fact, they even showed evidence of protection. Again, I wouldn't be surprised if the COVID vaccine, we start seeing some of the same questions that are arising with the flu shot. Can I get the flu from the flu shot? Can I get COVID from the COVID vaccine? So no, you cannot get the flu from the flu shot.
And I think it's also important to remind everybody that, if I get a flu shot today, I'm not protected today from the flu. It may be days or weeks before I'm fully protected. So I could go out and get exposed to the flu tomorrow and get the flu. And I think probably people relate that to, well, that must have been because I got the flu shot. The flu shot gave me the flu. Well, it's not. It may just be that you were in that gap of before you were fully immune after getting that flu shot, and you still got the flu. So that certainly can happen as well.
I think that's a segue into another question that is probably on the list, but it's asked a lot, which is, okay, I want to get a flu shot. When should I get the flu shot? Isn't it better if I just wait until we're closer to the beginning of the flu season, or when it's already started? If we were talking 2 months ago, I would have told you don't get it in July or August. That's too soon. And that's consistent with what CDC recommends. However, beginning in September, people should start getting the flu shot, and they should certainly have it before the end of October of this year, because of what you just said, Tommy. So it takes about 2 weeks to build up immunity or protection against the flu from a flu shot. If you wait until after the flu has already entered your community, we have definite cases of flu in the community, you're going to have a 2-week risk period. And you saw how sharp the peak was, the increase of the seasonality of the flu on the slide that I showed earlier. Once it's in a community, it spreads like wildfire typically. Hopefully this year it'll be different because of what we were talking about, the experience in Australia, but it will go up. And so if you wait too long to get the flu shot, you're going to be at risk a longer period of time than if you get it sooner. Now, why are some people suggesting to wait longer, or why do they think that waiting longer might help? Well, they say, well, we know that the flu shot loses its effectiveness after flu season is over, so why wouldn't I want to take it when this flu season starts, and that way it'll last longer, and I'll make sure that it'll last the entire season. Well, first of all, most of the flu shots given in September and October will have lasting immunity well into the end of the flu season. And then you don't want to start it late to get longer immunity if you're going to put yourself at greater risk initially because you took it too late.
Thanks, George. A good question about just, I think our recommendation, or is there a recommendation out there for, what does an employer do when an employee calls in and says, I'm sick? I've got one or more of those symptoms on there. How do you determine whether or not they have the COVID virus or the flu virus? I'll tell you what I tell my employers that call me is, especially during this time, it's COVID-19 until you prove otherwise. So I always recommend, if you can get a test, go get a test. Go get a COVID-19 test. We did a whole webinar on testing, so we're not going to get into that. Get a test for COVID-19. If it's negative, it can be that it's a false negative. It could be that you're just not testing negative yet for the COVID-19, or it could mean that you truly don't have COVID-19 and maybe you've got the flu. So in that case, that's when you would maybe consider running a flu test on that person and really trying to pinpoint what's going on with this person. I mean, regardless, if they're sick and they've got a fever and they're coughing and both tests are negative, you still don't want them at work, right? They still need to be home taking care of themselves. And then that's when you can have the discussion about, should they test later, or how long do they need to stay home? Is it the 7 days if you think it's the flu? Is it the 14 days if you think it's COVID-19? But with the advancements of testing at our disposal now, there's no reason why that person should not go and get a test if they're sick. Of course, that's an individual decision to make for that person, but I recommend, if an employee calls you and says, I've got a fever and I'm coughing, advise them to go get a COVID test and or a flu test, depending on how much you want to dig around. George, anything to add?
Yeah, so step number one is exactly the thing. Anybody who has symptoms, stay at home. That's rule number one. Then rule number two, if you're going to test, go with COVID first, because that is the main thing that we're looking for. Whether or not to flu test, some people ask, well, can't you just do both tests with the same specimen? The answer is yes. Sometimes it depends. So the CDC has put out a new test that can simultaneously, based on one specimen, test for both COVID and the flu. That's great news. What's not so great news is that it's only distributed it to state health departments. So these are not available in commercial labs. They're not available in most clinics, etc. Types of flu tests that we use in clinics, probably the one that y'all are most familiar with is what's called the rapid flu test. It's done in the clinic, and in about 10 minutes, 10, 15 minutes, you have a result. And that is helpful. It's not as sensitive as other flu tests, meaning you are going to miss cases of the flu, a real flu, because the test will come back negative even though you have symptoms. But when it's positive, it's helpful. The problem that we have this year is that the people doing these, taking the specimens and running these rapid tests, we have to be careful not to put them at risk from taking so many specimens and then manipulating them through different tests. When you go through a drive-through with COVID for COVID testing, you get swabbed, it gets put in a bag, it goes to a lab, and that's all that the employee does. Okay, but if you're asking them to take a couple of specimens, to put one in one medium, to run it through a machine, all of those are increased opportunities to put those employees at risk. And so, at least where I work, we've made the decision not to do rapid flu testing, and we're being very judicious about when we order a flu test at all, because most cases of the flu, once you've ruled out COVID, you can do what's called a presumptive diagnosis. If it fits the flu, especially if they tell you, hey, my wife has the flu and it was confirmed in her, you can use just that information without testing your patient for the flu and go ahead and give them Tamiflu or do whatever you think is necessary. So personally, I'm going to be reserving flu testing because of these risks that I explained, to very specific cases where getting the flu test result is going to make a meaningful difference in how I treat the patient. And this is likely to happen in those most vulnerable patients, where it may be critically important to know if they have the flu, COVID, or both.
Excellent. Question about the longevity of antibodies in the system. How far back, if you did an antibody test today, how far back is it going to detect? I will tell you that I've got a friend from church who all of her family was severely sick back in January. One of her sons was in the ICU, intubated, double pneumonia, could never figure out what was going on, right? They never could figure it out. This was before we really knew what COVID was. And I kept, we kept talking about this, and she kept saying, you know what? I think we all had COVID. And I said, well, let's antibody test you. We've got the means to do that now. She came in last week and tested. We did an antibody test on her, and she was positive for the IgG long-term antibody. So it just, anecdotally, she probably had it back then. Her family probably did have it back then. They said they felt like they were going to die and could not breathe, didn't want to get out of bed. One of her youngest sons, like I said, had to be in ICU on a ventilator, never could figure it out. Of course, everybody's visiting with no mask. We didn't know what was going on, but it looks like the long-term antibody is going to stay for a long time. Is that right, George?
We think so, in many people, but not in everybody. So the duration of this, well, first of all, we need to be careful not to confuse having antibody, and typically it's a specific type of antibody called the IgG, having a detectable antibody level, equating that with having immunity from the disease. It may not, okay? But second, knowing how long that IgG, that elevated antibody, is going to last. We do know that in some cases it disappears. And actually, I've had employees who have had bona fide COVID who then joined an IgG study that we have going on, and they tested negative, even though we know that they were positive. Typically, and again, there's relatively little data so far, but it's accumulating. It seems that people who had COVID with no symptoms or very mild symptoms are going to be the ones more likely to lose their antibodies down the road. People who have had severe disease and survived it appear to have longer lasting detectable antibody levels. But again, remember what I just said. Detectable antibody levels may or may not mean that there is immunity. And I would say the converse is true as well. We don't know if you had a detectable antibody level and then you repeat that test, let's say 3 months down the line, and it's disappeared, we don't know that that necessarily equates with losing any immunity you might have. There are certainly other conditions like hepatitis B, and we vaccinate for hepatitis B in healthcare workers all the time. We check to see if they've got antibodies, which for hepatitis B is an indicator of immunity, and they do, but over the years, they may lose it. And we know that even though they've lost it, if they were positive at one point in time, they probably still have ongoing immunity. We don't revaccinate them necessarily.
That's a good point to make.
Still.
A question came in about the permanent lung damage from COVID. What type of testing is being done to determine the long-term permanent lung damage? I mean, are we CAT scanning people? How are we knowing what the long-term damage is?
Yeah, I'm seeing a few of these because, you know, my background's also in pulmonology, and so I am seeing some folks who have survived. Typically, these are people who have survived a hospital stay, COVID, but they did have a hospital stay. Some of them, not all of them, were even on ventilators. So what I'm seeing is that most of the ones that I've seen, you know, when I see them in the clinic, I typically will get a chest x-ray at a minimum. Sometimes I'll get a CAT scan, but especially I rely on breathing tests. I do pulmonary function tests, and one of the tests that I rely on is probably one of the cheapest. Anybody can do it. If they go to Walgreens and buy one of those little finger oximeters, it costs about 30 or 40 bucks. And I walk them up and down the hall at a fast pace for about 6 minutes. And I look and see if their oxygen level stays the same, which is what should normally happen, or whether it drops. And so if it drops, that's an abnormal response. That may mean that they have some ongoing, you know, not complications, long-term effects from the initial disease. Now, remember that some people who were on ventilators, and this was even, I think I'm correct in saying this, I haven't seen the data, but just having viewed how our knowledge has evolved, early on we were putting lots of people on ventilators that, you know, nowadays we probably would try to avoid putting them on ventilators, because there is a little bit of evidence that the ventilators, although when you need it, you need it, but it can also cause harm, especially if you're administering very high levels of oxygen. You can get a condition called ARDS, Adult Respiratory Distress Syndrome, which in about 50% of cases of those people who survive it, they may be left with long-term scarring of the lungs. We've known this for years because ARDS is a common outcome of many different types of respiratory infections, and so we know a lot about that. So I would say that people who have had ARDS with COVID are more likely to have long-term lung damage than people who didn't have it, survived it, even if it was in their lungs, are less likely to have it. But there's still, we still not, I mean, again, we're only 9 months into it. So the people I'm seeing now, at the most, let's see, were people who had it back in April or May. So I can tell you that as of people, you know, the ones that I'm seeing in September, so 5 months earlier had theirs, the majority are doing okay, but I don't know. And likewise, the people that I've seen that have a residual defect have a residual defect or a problem, long-term damage now, but I don't know if they'll have it 2 months from now or a year from now. They might be better.
You know, there was some changing of guidance by the CDC when in regards to getting repeat tests. Repeat tests to show you're negative, and let's assume we're talking about a PCR test. So the question was, you've got a husband and a wife who both test positive for COVID. The doctor says, come back and see me after 10 days, we'll repeat the test. Husband tests negative, the wife keeps testing positive. Should the husband stay home with the wife until she's negative, or is he okay to go back to work?
You should be okay to go back to work as long as he doesn't have a fever. His symptoms are resolved, or at least are a lot better, and at least 10 days have elapsed since the start of his symptoms. You know, again, what we were saying before about immunity, we don't know how long immunity lasts. I personally think, and actually I think Dr. Fauci agrees, the famous Dr. Fauci, that anybody who has had a COVID infection is probably 100% of them develop some type of immunity. We just don't know how long it lasts. So they may be protected from future exposures for a good long while, and maybe over time they lose that, and then they're susceptible to what's called a reinfection, which is very rare, but we need to keep an eye out on that. I've stopped doing testing for return to work or anything like that. I just go by the symptom base, because we were having problems with people who we knew had recovered from their illness, but they kept testing positive, sometimes as long as 3-4 months after their original infection, and yet they were fine. And we now know that that has to do with the sensitivity of the test that is used, the PCR test, because it's detecting viral fragments that probably that are not infectious. Okay, and that's now been well studied. And so, you know, keeping somebody away from work 3-4 months, I mean, when there was no need for that, really takes a toll on employers as well as on the employees themselves.
Right.
So I've stopped testing. And CDC, if you look at their guidelines, they recommend don't repeat test within the first 3 months after you've had infection. They don't tell us what to do the 4th month. And by the way, now we're getting into the 4th month for a lot of people.
A question or a comment was about vitamin levels and severity of symptoms. Are you up to date on anything of vitamins, vitamin D levels?
Only I've seen some studies that low vitamin D levels may be associated with a worse outcome. And so if you have low vitamin D levels, frankly, if you have very low vitamin D levels, regardless of COVID, you would probably want to normalize them anyway. That's what we do clinically. Right. Vitamin D, we're learning, interesting, we've known about vitamin D for many, many years, but we're still learning about all of the different roles that vitamin D plays in the body. And there might be a role here, not so much that taking vitamin D protects you from COVID or its severity, but the fact that people with low vitamin D levels might be more susceptible to some of the complications or the severity of illness.
Question was, who calculates the reproduction rates for the flu and COVID? Where does that data come from?
So it's based on large data sets. Most of the data, I would say, come from state health departments. So here at the School of Public Health, and I mentioned this on previous webinars, our colleagues in the biostatistics and epidemiology departments have developed a fantastic website. If you're in Texas, it's called www.texaspandemic.org, all one word, Texas Pandemic, and it's free, obviously. And they actually take the analysis of the data a bit further than Johns Hopkins, which has done a fantastic job. But I think these guys take, you know, do even more detailed analysis. And one of the things that they do is that they plot the R0 value, the reproduction rate, and they base most of their data from state health departments. So I don't know what the calculation is, but I can see how it would be easy to calculate based on daily change in rates, existing infections and daily change in rates. You can probably calculate it. It's a formula, but the data will come predominantly, I would think, from state health departments or local health departments as well.
A question was on the dosing of the Tamiflu prophylaxis versus treatment. It is a little different. Can you know it offhand?
Yeah, once for 5 days, once for 10 days, I think. I could look it up while you're talking about something else. Yeah, I always have to look it up every year.
Yeah, me as well.
It is, you're right. It's different for treatment than it is for prophylaxis. I'll look it up while you're doing, find a question for yourself.
Yeah. So I think we talked a little bit about it, but the recommendation to wait a little bit later this year for the flu shot, late October. The question says late October, early November, but you're supposed to get it this year before the end of October. Is that right, George?
Ideally before October 31st, yes. Yeah. And
so before Halloween, and that's just to, you know, make sure that timeline is so you don't get it too early, but you don't get it too late. It kind of pinpoints a good cutoff by the time you should have it, because remember, it takes, you know, at least a couple of weeks to build up that immunity. You got the answer, George?
I do. So yeah, it was 5 and 10. I couldn't remember the dose. So Tamiflu is a 75 milligram tablet or capsule, I think. And if you have the flu, it's important that you start it, the sooner the better, certainly within the first 48 hours of onset of symptoms, and then you take it twice a day for 5 days. If you're around somebody who has the flu and you want to prevent it, you take it once a day, but for 10 days. Mm-hmm. So there's a trade-off. You get 2 a day for 5 days to treat it, or 1 a day for 10 days to prevent it.
Got it. A good question is this: the attendee asked, why is the recommendation to test around that 5th day period from when you think you were exposed, if you still have to quarantine for 14 days because you maybe test, you may get sick 14 days later, why not just either test and know it's negative and release you from quarantine, or just say, or test you throughout the 14 days? Is there any rhyme or reason to that?
Yes. So for the general population, the general community, people who are not involved in as first responders or healthcare, we typically will send them home for 14 days. And in many cases, that's it. You may not even need to test, okay? The whole thing about day 5 really occurs with people who don't have symptoms but have been exposed. When we look at the data of somebody who's been exposed, and it's been a confirmed exposure to somebody who has definite disease, symptoms start, they can appear, as you said, as early as day 2, but they typically, the majority of them start appearing at about day 5. Most symptoms will appear between days 5 and 8, but may not appear until as far out as 12 days, maybe even 14. That's the whole rationale for the 14 days. So, if somebody has symptoms on day 2, I don't wait until day 5. I test them right then and there. But if they're asymptomatic, we test them at day 5 because most of the cases will start becoming positive by then. If it is negative, it's no guarantee that they won't become positive 3 days later, right? It's just you're hitting them at the inflection point where a positive test is beginning to be really likely if in fact you have the infection. For somebody who is at home for 14 days and they're going to stay at home for 14 days, that's really not even necessary to test them. But remember that we had a severe shortage of healthcare workers. New York showed that amply, and hospitals had huge numbers of employees who were waiting at home to know since they had been exposed through the course of their work many times, they were waiting at home for 14 days. You multiply 14 days times hundreds of employees in some of these hospitals at any given point in time, and you've got a staffing shortage. So what was recommended said, okay, well, let's see if we can find a way to safely return them a little bit earlier, but still, not put people at risk. And so that's where the testing at day 5 comes in. We do it in hospitals. If people have had have no symptoms and they've had a known exposure, we wait until day 5 to test them. If they have no symptoms, if they've developed symptoms before that, we'll test them whenever they have symptoms. And at day 5, if they are negative, we'll let them go back to work as long as 2 things are met. There is strict adherence to wearing PPE at all times and safe practices and hand washing. We instill it in everybody, but especially in these folks. And number 2, should they develop any symptoms after day 5, they get pulled off the job and they get retested at that point. So it was a measure, and that helped a lot because it shortened 14 days to 5 days, and it helped with the staff shortages, which in some states were terrible, very severe.
There was a follow-up question to our husband and wife scenario about, well, why can't the wife go back to work? And I think she probably could, as long as it's been that full 10 days, she doesn't have symptoms. She's kind of caught herself up with repeat testing. So her employer may say, well, now we know you're still positive. We don't want you to come back. But I think medically she's able to go back to work with her husband as well.
Absolutely. And I think it's our role as healthcare providers to educate employers about that, because there are still, I think it's less and less. Some employers are still requiring negative tests after a confirmed infection to come back. And whenever I get the chance, I try to dissuade them from doing that. I try to convince them to go the symptom-based route that doesn't require testing after day 10.
Let's see here. So do we have any updated research on the efficacy of the neck gaiters versus other types of facial coverings?
I don't know about updated research. I mean, everything I've heard about the gaiters it is the least desirable form of facial covering. Certainly less than a mask, certainly less than a surgical mask. And we don't even want to talk about N95s, which offer the highest level of protection. Yeah, I think a lot of companies won't allow, that's my impression. Certainly we don't allow them in hospitals. We don't allow bandanas. We don't allow gaiters. We do allow cloth coverings on visitors when there are visitors. We don't allow them on our employees. They have to wear a surgical mask, a bona fide surgical mask, which offers greater protection than the cloth masks. But gaiters, we're not accepting them, at least in the hospitals that I have a relationship with. And my understanding is that many employers don't accept gaiters either.
Yeah. A question was on age groups for the COVID-19 vaccine. I haven't read anything about who they're testing it on or what age groups are going to be allowed to have it. Have you?
Yeah, well, so like the Moderna trial, 30,000 people, they have to recruit 30,000 people into the study, right? And they've been recruiting people. I mean, people are donating themselves, their time to the vaccine, but they have to make sure that the sample is widely representative of the US population. And they have been having trouble recruiting certain groups. And it's not necessarily age-based. I know that there's an age limit. I don't remember what Moderna is, but I know they've been having, for example, trouble recruiting minorities. And it's especially important to recruit minorities, Hispanics, and African Americans into these studies because we know that they are at greater risk, both of developing the disease and of having severe bad outcomes from the disease. About a couple of weeks ago, I heard something that they were still having trouble enrolling these folks. Age groups, I'd have to look at the criteria. But remember, you want to give the vaccine in people who don't have COVID. That doesn't mean they can't have underlying diseases, but people who don't have COVID, I'll look it up, and maybe when we respond back to the questions that we don't have a chance to cover, we can add that, Tommy, to the
Sure.
answer.
Let's see. Is there still a need for a vaccine if you have tested positive for COVID and recovered?
Don't know. We don't know. You know, and it's the first time somebody's asked that. I think it's an excellent question, and I think it's even more important that it be asked now rather than 3 months ago when we knew even less. So,
Yeah, I will say anecdotally, you know, I've had patients that we know had COVID, had pretty moderate symptoms. They recovered. We've tested them routinely over the past 6 months and have never shown antibodies to that. So what does that mean? We probably still don't know yet, but
right.
You know, some people will get this virus, recover, and probably still not have immunity at all for whatever reason.
So that raises the question, the very interesting and I think important issue of reinfection. Is it possible? A month ago, let's say 6 weeks ago, just to be safe, on one of our webinars, we were asking, there were 0 cases reported worldwide. There were millions of cases of COVID worldwide, but 0 cases of reinfection. And so we thought that it would be unlikely. That was nice because it suggested immunity, right? Mm-hmm. But then in the last 3 or 4 weeks, a few well done reports out of Hong Kong, there were Belgium, and then there was a case in Nevada in the US. Of true reinfection occurred. And so I began to worry a little bit about that because on the one hand, we've been saying all this time, you know, reinfection is not happening. And now we see a handful of cases. Then I wonder, well, why are we seeing a handful now? The interesting thing is they were all reported, even though in different countries, they were reported more or less at a similar time period, within about a 2-week period. And I said, maybe now that we're in month number whatever 7 of the pandemic, now we're going to start seeing reinfections, true reinfections arise because whatever immunity was there has been lost. So I think we need to keep our eyes out for reinfection. I'm not ruling it out. It's just incredibly difficult to diagnose. In these case reports, they did stuff to make sure that it was a reinfection, to prove it, that is not typically available in most hospitals. So the reason they were able to say it was reinfected is because they did special genetic studies, genome studies, and they saw that even though it was the COVID virus in both cases, it was a different strain, or there were differences in the genetic makeup of the 2 viruses. You know, typically hospitals don't have that type of test available for their patients. So clinically, it's one of the things I worry about because as I was anticipating, I'm getting more and more of these questions where somebody had COVID confirmed back in June. They went back to work. Maybe it was at a time when we were even testing people they had to be negative to come back to work. They came back to work. Now they've had another exposure 4 months down the line. And they're asking, what do we do? If I test them and they're positive, I don't know what that means. It may be that they're one of these persistent positives that are not contagious that we were talking about before, or maybe it's a true reinfection. So, and they don't have any symptoms. So, you know, my recommendation changes almost day by day as we get more and more of these, and I'm looking for more guidance, and it's not out there yet. So typically what I'm doing is if it's within the first 3 months after they had their infection, I don't test them. If they get re-exposed and they're not having symptoms, I don't test them. I let them work. Everybody's wearing full PPE in the hospitals anyway. And should they develop symptoms, I'm thinking I'll test them at that point. Yeah. But this is just my approach. It may change next week.
So talking about different scenarios in testing for the flu and COVID, you know, if an employee comes in and he's got signs and symptoms, right, of both, you test him for the flu first for whatever reason, and they test positive for the flu, and let's assume you don't have the means to test them for COVID, or they don't want to get a COVID test, so they've tested positive for the flu. The question is, should they be allowed to go back to work after the flu symptoms have stopped, or do they need to be quarantined for the full 14 days because you're assuming they may also have COVID?
Yeah, that's a tough one. I mean, I think you have to go clinically.
Yeah.
Right? If they have absolutely no reason to believe that they were exposed to COVID, there was nobody in their family, nobody reported having been positive that they were exposed to, etc. And the course of the flu follows the typical course of the flu, which is the one that you said, you know, abrupt onset, and then they get better completely within a time period. You know, I may be more inclined to say, okay, but actually when faced with these cases, I would do just the opposite. I would test for COVID first, and then I may or may not test for the flu.
Yeah, it's a tricky situation. The question was, you know, are there any advantages or disadvantages to testing employees on site at their job versus sending them all to a doctor's office? I'll just give you my opinion. Is it really doesn't matter. You know, we do it both ways. Employees get sent here, we test them. We also go out on site and test people. So I think it just depends on what you want to do, and if it's easier for us to come to you or a doctor to come to you and test 30 people versus sending them off site to go get tested. I mean, no rhyme or reason or negatives or positives to either one.
Yeah, the only thing I would add to that though, Tommy, is that whoever's doing the testing, make sure they know what they're doing. So you just said you go out to employers, but it's your team that's going out there. It's not somebody at the employers that is, you know, gathering saliva or, you know, swabbing people. Because there is a real chance of exposing the worker who's obtaining the specimen unnecessarily. So whoever does the testing needs to know what they're doing and to do it in a way that they are protected and protect others.
Absolutely, yeah. I interpreted the question as a doctor's office was going to come out, but it's a good point. I mean, you don't want the secretary swabbing somebody for COVID. Probably not the best situation. The age cutoff for the baby's age cutoff for a flu shot, is it 6 months still?
6 months. 6 months and above get a flu shot.
Yep. There was a good question by one of our National Safety Council colleagues in Chicago asking about an order of prevention methods, and what I'm gonna, it's a lot of them. So what I'm gonna do is we'll answer that in the spreadsheet that we send out, because it's a long list of things, and he's asking us to put it in order of priority or importance. So it's a great question, but I think it'll be easier if we just spell it out for everybody. If somebody does get reinfected, does it appear to be that it means the virus has changed?
We don't know. I mean, in the cases those 4 cases that I was talking about earlier, in 3 of them, well, I mean, in all of them, I think they proved that it was a different virus. It's still COVID, you know, SARS-CoV-2, the virus. It was just, it had a slightly different genetic makeup to just to prove that it was not the same virus that originally infected the person. Okay. So lost my train of thought there. Yeah, so reinfection can happen with a different virus from a different exposure. I guess that's the easiest way to say. There, in both cases, in all the cases that I know, it was there was a confirmed new exposure that led to the case. It wasn't that somebody had an exposure, developed the disease, and then 3 months later developed the disease again without any known re-exposures. In all the cases, there was a re-exposure. And in 3 of the 4 cases, they were very promising because the reinfections were much milder than the first time around. However, the one case in the US, in Nevada, was sicker than the first time around. So I guess all bets are off on that one too.
Well, you know, I know we've reached our time limit here, and we actually did a great job you guys did a great job of sending in questions. We answered, looks like all but maybe 3. So I think what we'll do is end it here, and we're going to answer those last remaining couple of questions in the spreadsheet that we send out. So you're going to get a link to the video of this, the recording, as well as the spreadsheet with any unanswered questions. That way you'll have all the answers to everything that you asked. So we appreciate it again. I think we had around 200 people on the webinar today, which is a great turnout. And you know, if any other topics come up or you want any more topics to be presented, feel free to ask us, and we'll do our best to make sure that we can provide you with some education. We appreciate it, everybody. Thank you. Have a good, safe week. Happy fall, and go get your flu shot.
Thank you. Please do. Take care.
Bye-bye.
Bye, Timmy. Thank you, Jordan. Thank you, Michelle.